So this evening we'll be discussing renal replacement therapy. All right, as a background, we'll look at the indications for renal replacement therapy, and we mentioned them in our last discussion. I'm going to go over it again. When do you offer your patient renal replacement therapy? When do you think that this patient has earned himself or herself a renal replacement therapy? And those are the indications that we're going to be looking at. I don't know, I can't remember if I discussed that with us before, but let me see. Yes, so indications for renal replacement therapy by way of incidence and epidemiology. About 7 out of 10 patients with acute kidney injury will require renal replacement therapy. As high as 70% of patients with acute kidney injury will require renal replacement therapy during the course of the disease. I like mnemonic, so I put remember Father P. Remember Father P. And F there is fluid overload. For patients who are fluid overloaded, A represents anuria, when patient fails to make urine or less than 100 ml of urine in 24 hours. Patients who are in metabolic acidosis with a pH less than 7.2. Patients with toxemia, toxins, and poisoning, all sorts of toxins will require renal replacement therapy. Hyperkalemia with potassium persistently above 6.5 millimole per liter. Encephalitis, refractory GI symptoms, and pericarditis, or you like to say constrictive pericarditis. Any of these present in the patient is an indication for renal replacement therapy. There's a popular one that I'm sure we are aware of. Think about the vowels. The A, E, I, O, U. A stands for acidosis. E stands for electrolyte disturbance, especially hyperkalemia. I, intoxications with lithium, ethylene glycol, etc. O talks about fluid overload or volume overload. And the U stands for the presence of signs and symptoms of uremia. So by the time you combine these together, you will have a fair knowledge about the indications for commencement of renal replacement therapy. All right, by way of going forward, I always like to involve the nephrologist as early as possible. And most units where I work, we have dialysis room where our patients who are on ventilator and notropic support can easily be dialyzed without moving them to any dialysis unit or center elsewhere from the intensive care unit. So 2 things, I like to always involve the nephrologist as early as possible, and we agree together on the indications for renal replacement therapy. Sometimes refractory hyperkalemia may have been attempt at treating it may have occurred with your shifting, intracellular shifting of your potassium. But when it becomes refractory at high as 6.5 with all the signs and symptoms of uremia, the patient ends him or herself renal replacement therapy. So let's go into it more properly. Renal replacement therapy can be classified according to one, the mechanism of solute removal. Number two, it can be classified on the basis of duration of treatment. On the basis of solute removal, we have dialysis. All right, solute removal is by the process of diffusion. While filtration, the mode of solute removal is convection. And we know all this in chemistry. In terms of duration of treatment, duration of renal replacement therapy, it can be a continuous process or intermittent process. Remember, just a way to remind ourselves that diffusion is a process by which substances move from a region of high concentration to low concentration across a semi-permeable membrane. All right, so electrochemical gradient is usually created across a membrane using a flow path system with a toxin-free diacylate solution. All right, so the process of intermittent hemodialysis and peritoneal dialysis is based on the process of diffusion. Infiltration, which operates by the process of convection, there is the presence of a transmembrane pressure driven known as solvent drag, which is created where solute moves together with the solvent across a porous membrane. All right, so there's a solvent drag. The solute that you want to remove moves along with a solvent across a porous membrane. And this is what is utilized in cases of filtration, hemofiltration. The ultrafiltrate is then discarded, and this is replaced with the toxin-free replacement fluid or your hemodialysis fluid. I hope we understand that. It's important for us to clarify the types of renal replacement therapy that is available in the intensive care unit. A lot of times, just to lay an emphasis, I prefer hemofiltration. All right. And if there is not possible, and you have only hemodialysis that works by diffusion, it's better you have an intermittent hemodialysis. All right, because that gives a better hemodynamic compromise in terms of ensuring adequate blood pressure. All right, so hemodialysis, like I mentioned before, this is a removal of solute by diffusion across the semi-permeable membrane, and it uses the mechanism of contact current exchange. Blood is removed at 200 to 300 ml per hour, all right, while the diacylate is removed at 500 to 800 ml per hour. I hardly do more than 500 ml in a day for hemodialysis, especially for septic patients who have hemodynamic compromise. A lot of times, it depends on the pH status, that's the acid-base balance, and the amount of solute that needs to be removed. We can do 500 ml in 2 hours. But give or take, I don't like to give more than 500 in a day. All right, with removal of 200 to 300 ml per hour, you actually can achieve the day's worth of solute clearance in just a few hours. In hemofiltration, it uses hydrostatic pressure, like I mentioned, solvent drag. You put a diacylate, and the solute to be removed follows the solvent, the diacylate that you have introduced to the mechanism we call solvent drag. All right, this usually reserved for molecules less than 50,000 Daltons, which are dragged across the membrane with the water by the process of convection. The filtered fluid known as the ultrafiltrate is discarded and they're replaced by hemodialysis fluid, which is adjusted according to the desired fluid volumes. Now listen, hemofiltration removes larger volume of fluid, almost about 10 times than that which is removed by hemodialysis, because you can remove at as much as 3 liters per hour, all right? But you do this slowly compared to hemodialysis. All right, we have a combination of hemodialysis and hemofiltration in what we know as hemodiafiltration. Now, this combines the process of filtration and dialysis, and it has been found to be useful in increasing solute clearance. The beauty of it is that it combines the benefits of dialysis and filtration. The other one is what we call the slow continuous ultrafiltration. Slow continuous ultrafiltration. Let me just do this as we continue. Slow continuous ultrafiltration is used when, in case of fluid overload, all right, when the only requirement is water to be removed, especially in fluid overload. Now, it requires very low filtration rate, and it can remove as high as 6 liters of fluid, all right, without a solute remover. So, slow or continuous ultrafiltration is reserved for strictly volume overload, all right, in cases where you have, anasaka or patients with pulmonary edema, when all you want to do is to remove free water from the body. Now, this slide shows us, let me do slide share. This slide shows us the differences between hemodialysis and hemofiltration. Like I mentioned, all right, this is the patient's blood mixed with diacylate, all right, and this is the semi-permeable membrane. So you pass the blood through it, and solute move from the regions of high concentration. You can see here, this is high concentration semi-permeable membrane. So the solute moves across its electrochemical gradient into the diacylate, which is eventually discarded for the patient. Hemofiltration, there's a semi-permeable membrane, but the solute that is being removed follows the hydrostatic pressure that is created by the solvent, and that's where we have what we call the solvent drag. All right, hemodialysis, all right, works by diffusion, while hemofiltration works by convection. You can see that the diacylate, like free water that you add, all right, pushes the solute from the blood into the ultrafiltrate section, which is then removed. And as you remove that, you replace what is being removed by your water or your hemodialysis fluid. All right. This is just another schematic diagram telling you how this works. The beauty of hemodiafiltration, like I mentioned before, combines the benefits of dialysis, hemodialysis, and that of ultrafiltration. So in terms of duration of solid removal, we have the intermittent hemodialysis, which is commoner in resource environment, resource poor environment, like the low income or medium income countries. All right, there's a high flow rate for a defined period of time. All right, and you remove almost 300 to 400 mils per hour. All right, and a lot of times this is reserved for patients who are cardiovascular stable and patients who are on long-term renal replacement therapy, like patients who have chronic kidney diseases. It's not commonly used in ICU. I mentioned this. And large volumes of fluid are removed over a short period of time. That reduces your circulating blood volume, and that will lead to reduced cardiac output and hypotension, of course. And this, the resultant hypotension, all right, may eventually delay renal recovery. So you are in a circle, all right. You're dialyzing the patient, but you are pushing the patient to hypotension, leading to renal hyperperfusion. And with renal hyperperfusion, you have delayed renal recovery. So the patient continues to be in chronic state of renal impairment. All right, it results in inferior uremic control and acid-base control because solid removal is episodic. All right, there's limited fluid and uremic control, imposes limitation to nutritional support. All right, and more importantly, there could be a rapid shift of solute, which may cause cerebral edema and predisposing the patient to raise intracranial pressure. The second mode of renal replacement therapy based on duration of solute removal is what we know as the continuous renal replacement therapy, CRRT. This is commoner in the ICU, and the basis of it is that there's filtering or dialysis on a continuous basis. All right, usually initiated with a blood flow of 100 ml per minute, and gradually you increase it. All right, continuous renal replacement therapy is inherently complex. All right, requires the use of anticoagulation, and you need high volumes of fluid, and it's more expensive compared to intermittent hemodialysis. And this explains why the intermittent hemodialysis is commoner in resource-poor environment. There are different types, all right, but more importantly, continuous renal replacement therapy is considered for patients with cerebral edema with fear or risk of raised intracranial pressure. Patients who are hemodynamically unstable, especially those who are on inotropes. Persistent ongoing metabolic acidosis, we call it refractory metabolic acidosis, and for patients that require large removal of fluid. All right. There are different types of continuous renal replacement therapy. Okay. There are different types. We have the slow or continuous ultrafiltration, SUUV. Okay. We have the continuous venovenous hemodialysis, hemofiltration, hemodiafiltration. And one of the ones I like so much is the use of SLED, slow, low efficiency daily dialysis. This is ideal for critically ill patients being managed in the ICU. The advantages are many because one, it creates a better fluid management and causes less hemodynamic disturbances. All right, all right, it provides the opportunity to provide protein-rich nutrition while the patient is achieving desired uremic control. There's a better control of electrolyte, all right, which also includes and not limited to potassium, but includes phosphate and calcium. All right, and because it's a continuous daily thing, it prevents the swings in intracerebral water, minimizes risk of infection. But how be it, with all these advantages, it's more expensive and requires continuous anticoagulation. All right, so if you are seated with a patient that you have agreed, you have confirmed that this patient will require renal replacement therapy, you want to look at how to achieve this. So the first question you want to ask yourself is, what do I want to remove from this patient system? All right, what is the size? All right, and this will help you to determine, especially if you're in the setting where you have a variety of renal replacement therapy options. All right, so if your decision is to remove small molecules or electrolytes with less than 500,000, 500 Daltons, this includes uh, electrolytes and molecules like urea, creatinine, potassium, hydrogen and lithium. You could either use your hemodialysis or filtration. For particles between 500 to 5,000 Daltons, for instance, in case of toxicity, drug toxicity like vancomycin, filtration is better than hemodialysis. Low molecular weight proteins like 5,000 to 15,000 Dalton size, like cytokines, especially during the COVID era where you have cytokine spike. All right, most of them were ordered hemofiltration. Water, if it's fluid overload, water with the size as 18 Daltons, filtration is better than dialysis. The reason I put this table here is to, inform you that dialysis or renal replacement therapy is not a one-size-fits-all. You need to know and determine from your ABG or from your blood work or your labs, what do I want to remove and for how long do I want to remove these particles or these substances from the blood. It will help you to determine the preferred type of renal replacement therapy that will benefit the patient. Okay, I've mentioned all this before. All right. Now, when we're talking about complications of renal replacement therapy, in as much as it's a very useful treatment adjunct, it's not without its complications. All right, and I got this from the study, or this is by Alex, or who works in Sydney, published this in the Range Physiology Journal, and enumerated all of these complications, ranging from complications related to vascular access. So when you ask complications of renal replacement therapy, you need to break them down. All right, it will help you to remember. So complications associated with vascular access, bleeding, vessel damage, you could introduce bloodstream or localized infection. And especially for patients who are being ventilated, you can have what we call embolism. All right, you can have respiratory complications like hypoxia. All right, this is due to activation of complement and inflammation mechanisms. All right, that consumes oxygen at a faster rate and leaves the patient at the risk of hypoxemia. Hypercapnia can occur because some molecules of carbon dioxide will diffuse through the membrane and into the diacellate, and you are passing through this to the blood, so you increase your partial pressure of carbon dioxide. Circulatory wise, we know that it causes, especially intermittent hemodialysis, causes severe hemodynamic instability. Hypothermia, returning blood is usually very cold. By the time you are returning the blood to the patient, it has gone through a lot of processes and it's cold, it's no longer at the patient's body temperature, so cold. We can have hematological complications, either from the use of anticoagulation or even from, the activation of your coagulation cascade, your tissue factor, and all that can lead to hemolytic complications. You can have blood loss due to circuit loss. All right, some of the blood that is supposed to pass through the diastole and return to the patient may actually be lost in transit. The commonest fatal complication of renal replacement therapy is the dialysis disequilibrium syndrome. All right, and these are CNS complications which arises due to rapid and large movement of small solutes from the vein. These solutes have actually accumulated in the brain and have gotten a steady state. But when you remove this solute from the brain, and it becomes, you have what they call disequilibrium syndrome. So the uremic waste in the brain becomes substantially greater than the extracellular fluid that you have removed from. Now, you can actually have hypo or hyperelectrobulimia, all right, if you have too much removal of water. When you remove too much of water in excess of electrolyte, you can have what we call concentration, and the electrolytes may shoot up. All right, delayed renal recovery may occur, like I mentioned, especially with intermittent hemodialysis, with occurrence of hypotension, leading to hypoperfusion of the renal vasculature, and you have problems, leading to delayed renal recovery. For patients on intermittent hemodialysis, that you cannot initiate adequate nutrition, you can have malnutrition due to dialytic nutrient loss. All right, and because dialysis on a daily basis removes any useful nutrient that may be present in the blood. All right, if you like summary like me, Benjamin Gladwin provided a summary, and for which I've given credit to Ham. All right, so complications of renal replacement therapy, it can actually elicit inflammatory response, leading to cytokines and all that. And this also can lead to increased oxygen demand and consumption, leading to hypoxemia. There could be blood loss. We mentioned this, access complication, vascular access, thrombocytopenia, hypoxia, electrolyte disturbance, hypothermia, all right, anemic complications, and malnutrition. Don't forget this in case you're asked. All right, why did I put this here? Okay, disequilibrium syndrome is a common short answer questions, especially at postgraduate level. And you are asked, what is dialysis disequilibrium syndrome, DDS? All right, how do you manage it? All right, so DDS is characterized by a range of neurological symptoms that affect patients who are on hemodialysis, and incidence is common among those who are on dialysis for the first time. So first-time dialysis patient at increased risk of developing DDS, and therefore we should have a high index of suspicion for this group of patients. Also, patients who have missed their dialysis sessions for a consequent number of times, and when they are coming back on dialysis machine, they are at increased risk of dialysis disequilibrium syndrome. By way of pathophysiology, DDS develops primarily from an osmotic gradient that develops between the brain and the plasma as a result of rapid hemodialysis. All right, like we said, there's differential gradient. So you're removing solute from the plasma, from the blood, but solute, uremic solute that have accumulated in the brain are still there. All right, so there's a loss of imbalance, and that's what we call it disequilibrium. All right, so this results in brain edema, which may manifest as severe headache, nausea and vomiting, muscle cramps, tremors, disturbed consciousness, and convulsion. In actual sense, patients can actually die from the cerebral edema that may occur because the solute in the brain begins to draw water from the body through the process of osmosis. All right, the good news here is that DDS has rarely been described in patients who are offered continuous renal replacement therapy. What are the etiological factors for DDS? First, hemodialysis treatment. initial high blood urea, nitrogen, patients at extremes of age, when you have a sudden change in dialysis regimen. And this is important. If you have a patient who has been undergoing dialysis before presenting to you to the ICU, it will be good to know the former dialysis schedule, and that will help you to plan, for this patient, because if there's a sudden change in dialysis regimen, you may have disequilibrium syndrome. Pre-existing neurological disease such as stroke, malignant hypertension, and all that could also predispose patients to DDS. Presence of other conditions causes cerebral edema, makes sense. All right. Now, how do you prevent this? Slow, gentle initial hemodialysis. And that's why it's been rare. It has not been described, so to say, commonly in patients who are on continuous renal replacement therapy. All right. You try to use a high sodium diazolate, or what we call sodium profiling, and administration of prophylactic administration of osmotically active agents like your mannitol or hypotensive saline that are traditionally used in the management of cerebral edema can help prevent this Peliron syndrome. Now, for patients who develop seizures while on dialysis, you need to discontinue the dialysis as soon as possible until the seizures and vital signs have been managed. All right. Be careful that there are some anti-epileptic drugs that are not cleared by dialysis that may actually worsen the patient's acute kidney injury. All right, KIDCO, all right, Kidney Disease Improvement Group, all right, recommends in 2012, about 10 years ago, all right, yes, 10 years ago, how acute kidney injury should be managed. It's a guideline, a recommendation. All right, so the first thing is when you have a patient with acute kidney injury, you want to stage it according to KIDCO criteria into stage 1, stage 2, stage 3. Number 2, you don't treat blindly. You want to determine the cause of AKI and, if possible, manage it. All right, a lot of times we don't do this, but a high index of suspicion with testing patient at risk of AKI to detect it early. All right, fluid, the choice of fluid in patients with AKI, all right, depends on the cause, especially for fluid depletion. All right, if it is not hemorrhagic, it's better you use isotonic fluid for volume expansion. Do not hesitate to combine vasopressor with your fluid. All right, and interestingly, diuretics are not recommended in the prevention or treatment of AKI, except there's documented evidence of fluid overload. Low dose dopamine is not recommended. I know somebody mentioned it last week and we discussed it. So it's not recommended. Every antibiotics that are cleared by the kidney should not be used. And once you have cleared indications, you should commence renal replacement immediately and discontinue it when it's no longer used. All right, on the right side of the screen, you can see proposals or guidelines for instituting renal replacement therapy. So you want to use an uncuffed, non-toilet dialysis catheter. All right, the right internal jugular vein is preferred to femoral, which is preferred to left internal jugular vein, and left internal jugular vein is preferred over subclavian vein. Now, with all your central line, after inserting your central line, you want to obtain a chest X-ray, all right? And by all means, especially in patients who are stable hemodynamically, patients who have acute injury, raised intracranial pressure, evidence of brain trauma, brain edema, it is advisable that you use a continuous renal replacement therapy. Okay, I didn't mention this before, all right? There are some controversies in the management of AKI, and the issue is that some studies have looked at the association between the use of furosemide, all right, with outcome in patients with acute kidney injury. All right, according to the guidelines that were followed, AKI is the use of furosemide, all right, remains very uncertain. Some you still use, like I do, some don't, all right. So they conducted a study to investigate the association between the use of furosemide and outcomes in critically ill patients in their unit. All right, a total of 14,000, more than 14,000 patients with AKI were included in the study. All right, and they found out that furosemide was associated with reduced in-hospital mortality. All right, with a p-value less than 0.01, which is a strong significant factor. They found out that the use of furosemide was associated with reduced in-hospital mortality. And it was also observed from this study that furosemide was also associated with recovery of renal function. Okay, so the study concluded that furosemide administration was associated with improved short-term survival and recovery of renal function in patients who are in the intensive care unit. All right, and remember that we said that if you're managing patient with AKI, follow the KIDCO criteria. And they said that furosemide was especially effective in patients with acute kidney injury, KIDCO stage 2 to 3. All right, and this is important. If you're using urine output, stage 2 or 3, but it was found not to be effective with creatinine stage 2 and 3 with those with chronic disease. All right. So this is just talking about the use of furosemide in patients with AKI. Other studies went ahead to look at the same group of researchers, tried to compare continuous versus intermittent use of furosemide. And it concluded that continuous intravenous infusion of furosemide resulted in significantly greater diuresis than bolus intermittent administration. All right. And they found that there was no difference in terms of side effect or mortality, whether I use intermittent bolus administration of furosemide or use a continuous infusion. The study did not record any difference between the two groups in terms of patients' mortality or side effect. All right, all the studies have looked at what are the potential rules. Does furosemide have any role to play in the management of patients with acute kidney injury? And a lot of things were said. In fact, one of them, interesting to me, was that the use of furosemide resulted in less or shorter duration of mechanical ventilation, and at the end of the day, reduces length of intensive care unit stay. All right, this is important because the use of furosemide will keep the lungs, dry. Like I tell my people, the dry lung is a better lung, is a happy lung. A dry lung is a happy lung. So with furosemide, and you keep the lungs dry as much as possible, you reduce the duration of mechanical ventilation. And by so doing, you reduce the length of ICU stay. All right. It's been found out that urinary response to furosemide injection has been used as a prognostic test to predict the risk of requiring renal replacement therapy. So before you actually offer the patient renal replacement therapy, a lot of us would have given furosemide from the onset of the AKI Okay, these are some of the things I'm going to leave with you. All right. There are a lot of also pitfalls. Okay. And some studies have found that furosemide use can induce hypovolemia, hypokalemia, and all that, with all the catastrophic consequences. It has also been found to be useful in differentiating between hypovolemia and normovolemia, all right, in patients who are come down with AKI. And it gives a false hope, because it delays the commencement of renal replacement therapy, and this may actually increase mortality. But here, clinical judgment is important, and what you have available in your center. If you do not have renal dialysis, why don't you give your patient furosemide? Or at high doses, it can induce ototoxicity and reduce renal clearance. All right. Many of them, it can cause systemic vasoconstriction. All right. That also reduces your cardiac output and all that. I'll leave it with you. There are a lot of drug interactions with furosemide. Either it declares, it reduces clearance, all right, or whatever it is. It may also hinder transport of drugs to the appropriate site for clearance. All right. So early diagnosis and prompt intervention prevents fatal outcome in acute kidney injury. And don't forget that in any multi-organ failure cases, the kidney is the first to fail. The kidney is the first signal. And it actually resolves, all right, as soon as the primary insult has been taken care of. Okay, so these are my references, and I have a couple of questions at the end of it for us to look at. All right, ladies and gentlemen, any question?